So this is really my passion in my career is really bringing together the kind of practical components of practice as a surgical pathologist as well as molecular diagnostician. And for this talk, I chose to kind of bring in some major infrastructure projects as kind of a metaphors for the sort of ambitious undertakings that we're facing in pathology and really blending a lot of different technologies to advance our practice. This is the Triborough Bridge in New York City, where traffic is coming together from Manhattan and I think the Bronx and Queens, and was a really massive undertaking back in the mid-century, mid-20th century, with its fair share of controversy associated with getting this type of project done. This was a Robert Moses project. If anybody's read The Power Broker, you'll know a lot about it. I recommend the book. But in any case, after that preamble, I will try to advance my slides, which is not my forte, evidently. There we go. So I have the following disclosures. And then these are my objectives. So I think I'm obligated to walk through these with you. So we'll talk a little bit about advances in the molecular diagnostics space, which all of you are well aware of, that have informed the way we're thinking about tumor classification, specifically really for kind of garden variety surgical pathology questions with an emphasis on processes occurring in the chest. Define a couple of examples where we're implementing more immunohistochemistry that's based on molecular alterations to aid in our own diagnostic practice, and then think about how that translates into some cost-effective strategies for diagnosis. So we'll start with essentially it's a two-part talk. We'll start with part one and another infrastructure image. This is, for those of you who've spent some time in Boston and Cambridge may recognize this image. This is actually Fresh Pond neighborhood in Cambridge, and this is two of the busier traffic circles in our city. And this is clearly like peak pandemic image, maybe 6 o'clock in the morning because there's zero traffic. Usually it doesn't look like this, but sort of again metaphorically, there's a lot of inputs that we're incorporating into our practice, and so we'll talk about those now. And also as kind of a tribute to how we often present cases or present talks at the Brigham, we like to start with a case presentation and kind of build from there. So we'll start with a case here, and it's that of a 66-year-old woman. This is a patient whose pathology we reviewed over the last couple of years, most recently in 2021. When she presented with a liver mass. She has a very relevant past medical history, including of an epithelioid mesothelioma that was originally diagnosed around 2019. She had neoadjuvant cisplatin pemetrexed therapy for that, and then they attempted to do a pleurectomy and actually had to abort in the middle of the procedure because they realized her disease was just too extensive and they couldn't get it all out. That said, the tissue that we received was essentially pure epithelioid meso, and that's the diagnosis she was carrying. Given the really failed surgical, the attempt at a surgical cure, she underwent a clinical trial of pembrolizumab, PD-1 inhibitor, and as we know, there's a subset of mesothelioma patients who actually respond to checkpoint inhibitors, and it seems like she was likely one of them. At least she had fairly prolonged, stable disease on the therapy, and then appeared to be having some slowly progressive disease in the chest over the last 6 months to a year. During the workup for her meso, they incidentally detected a breast cancer, and it was an ER/PR positive, MOD-diff, mixed ductal lobular cancer, pretty garden variety. She underwent a lumpectomy, margins were negative, overall risk factors were relatively minimal. This was also in 2019. So it's kind of interesting that we have a combined, a simultaneous essentially mesothelioma and breast cancer diagnosis in this patient. It kind of gets you thinking about maybe any other underlying processes that could be going on with her. But as far as we know, these are the only tumors that she has. And here we are now in 2021, and she's now undergoing kind of routine imaging, and they detect this liver mass, and they decide to proceed with a core biopsy, which is shown here. I'm not sure how well it's displaying here. You can probably perceive, or on Zoom, but you can probably perceive that it's mostly necrotic, and that's kind of par for the course for many of these diagnostic biopsies. If we zoom into the one tip of the specimen that appears to be viable, you can see here at intermediate power view that it's a pretty admixed population of cells, including a lot of inflammation, a little bit of entrapped bile duct elements here, probably over on the edge. And then at higher power, you can begin to perceive an atypical cellular population, large cells, sort of epithelial to spindled, really pretty nasty looking. Morphologically, hard to say what exactly this is. We need stains, obviously. So here's a panel that was run, and the two stains that came out as positive were GATA3 and CK7. WT1, calretinin, two of our typical mesothelioma markers, were negative. Claudin-4, which we typically associate more with an adenocarcinoma biology, that was negative. CK20 was negative. So in this context, history of breast cancer, history of mesothelioma, negative mesomarkers, GATA3 positive. It's a breast cancer, right? So that's what it was called, favorite metastatic breast cancer. And as per protocol, the case was sent to the breast service to do quantitative analysis of hormone receptors and HER2. And the ER and PR were negative in contrast to her prior sample. HER2 was negative. And the breast pathologist was like, I mean, I guess this could be breast, but you take a relatively low-risk breast cancer and you find it as this hideous sort of sarcomatoid-looking thing in the liver 2 years later. It's a little bit of an unusual process, and for it to have lost its hormone receptor status, I mean, it's possible, but it's just slightly unusual. I don't think it's metastatic breast cancer. And so it got kicked over to the thoracic service, and we said, well, she does have this history of meso. Maybe it's that. Maybe we should work it up further. And here's just a quick reminder for those of you who haven't been digging around in literature on these topics recently. GATA3 is, as we know, widely expressed in breast cancers, but it can certainly be lost in poorly differentiated breast cancers. But in well-differentiated ones, we'd expect to see it in greater than 90% of the cases. But it's also expressed in apparently more than 70% of sarcomatoid mesos. So I think this is one of those things that falls into the kind of little-known fact category and potentially easy to ignore that possibility if you're not thinking about it. So what about CK7? Here the data looks like it's all over the map. There was one study that suggested you could see CK7 in mesotheliomas, and of course it's very commonly expressed in breast cancers. You could see it in the majority of mesos, according to one study, and you see it in 0 mesos in another study. So I think we maybe have to discount the CK7 literature for now, but the GATA3 is really interesting. So, so the question becomes, what do we do next in this scenario? And so you could quibble with our decision to do these two markers in this particular case. We chose to do a BAP1 and an MTAP really more out of desperation than anything, because we didn't actually know what the status of these markers were in the mesothelioma from 2019. We didn't really have a reason to run them back at that time. What you can probably perceive is that they both appear to be intact. And so this doesn't really tell us anything at all, is the bottom line. So then the next step became, let's pull the pleurectomy from 2019. And indeed, we confirmed that it was an epithelioid meso, pretty much a pure epithelioid meso in the specimens that we received, of course, keeping in mind that she had a bunch of disease that they never got out of the chest. So we don't actually know if she had a component of sarcomatoid meso left behind. We also chose to do the BAP1 and the MTAP on this biopsy, and they were intact here. So, maybe it is her meso, and it just, these two biomarkers that we often see lost in this disease just happen to be intact in this case. So now what do we do? And then here's where we sort of get into like these discussions around integrating molecular diagnostics testing as a part of our diagnostic practice. And it gets a little tricky for us from a reimbursement standpoint. We assume we're not going to get paid if we actually initiate the request for testing using our, say, next-gen panel. We have a 450 gene panel that we use routinely for predictive biomarker testing and prognosis and things, and that's typically ordered by our clinicians, and there has to be very clear documentation in the chart about justifying why they're ordering this test. Rather than us ordering it and then hoping we can get reimbursed by somebody later, we ask our clinicians to make sure they justify it in their clinical notes and then place the order for us. So that's what we actually did in this particular case. We said, we're not sure what this is, but maybe molecular profiling will work. Can you place the order for us? Is this a worthwhile endeavor in this particular case where the question is it breast cancer? Is it an unusual breast cancer, or is it a sarcomatoid meso in somebody who doesn't have a known history of sarcomatoid meso, only epithelioid? Or, of course, it could be something else entirely, right? She already has a little bit of an unusual cancer history. Maybe this is a new, really poorly differentiated cholangiocarcinoma that has some weird GATA3 aberrant expression. Who knows? So at this point, the differential diagnosis is still very broad. You could argue at least that if you have a kind of discrete question of breast versus meso, maybe molecular is a helpful strategy for making that distinction, given that breast cancers we typically associate with PI3 kinase pathway activation, maybe some MAP kinase activation. Mesos, of course, we associate with BAP1 loss and NF2 loss. SETD2 is another relatively specific marker in this differential. Of course, they could both have maybe CDKN2A loss and P53 mutation, and that wouldn't help you make the distinction. But let's give it a try and see what we find. So here's the results of our gene sequencing. And what you can see is that we have 4 variants that appear to be somatic in this patient's sample. 2 that are bolded, NF2 and SETD2, certainly kind of push you towards a mesothelioma possibility. You can see there's a note here that tumor content was too low. We've got VAFs in the 5%, 4 to 5% range, and of course it depends on how you validate your assay, but there certainly may be practitioners who are not super comfortable with kind of hanging their hat on variant allele fractions around 5% for a sequencing assay like this. I'd also point out that there's a B2M mutation, which is kind of interesting in the context of this patient having received pembrolizumab therapy, because we recognize this is a known acquired resistance mechanism to checkpoint blockade. For me, looking at this, and I think I'm a little bold sometimes, maybe inappropriately so, but I would look at this gene panel, and if I were signing this out, I would say this is mesothelioma, and I would kind of close the book on it. It's not the patient's breast cancer. In general, I think we try to be a little bit more conservative than that, and certainly our clinicians really like, are you really absolutely certain the decisions around the therapy is going to be dramatically different if we think this is metastatic breast versus meso? So just to emphasize that these are the genes you find in meso. So why don't we go ahead and actually sequence our pleurectomy from 2019 and just be absolutely sure. So that's here. You can see pretty much the same mutations. I think we've kind of, put the final nail in the coffin. This is the patient's recurrent mesothelioma in the liver. Note that there's no B2M mutation back in 2019, so that confirms it was an acquired event. And we had a little bit more tumor in the specimen in 2019 relative to the 2021 biopsy, and you can begin to perceive some of the relatively typical copy number alterations. Again, relatively low tumor content, so they're not particularly dramatic, but seems to fit with meso. So can we make this a little bit, can we expedite this process a little bit? Like, what if we can bring in a couple more markers on the IHC side that correlate with the changes that we see in the genomics of, say, a mesothelioma? And so one of the things we've been excited about validating in the last year is Merlin, which is the protein product of NF2, by immunohistochemistry. And as we were in the process of validating this particular antibody, we thought we'd throw it on this case, and indeed showed that it is the protein is clearly lost in both her original epithelioid meso as well as the liver met from 2021. So in sum, at the final diagnosis, we had a metastatic spindle cell neoplasm consistent with spread from the patient's pleural mesothelioma. We noted there's an acquired beta-2M mutation. And the question remains, is the patient's original meso actually biphasic and completely sampled, or are we actually seeing kind of an evolution to sarcomatoid meso that's driven by this course of therapy? We'll never know, but at least we think we have a kind of parsimonious diagnosis at the end. So going back to this issue of validating NF2, the real reason we wanted to validate NF2 is this perennial question of making the diagnosis or the distinction between reactive mesothelial hyperplasia and malignant mesothelioma, which those of us who see a fair amount of mesothelioma in practice often struggle with this distinction. And at this point, and based on the kind of flow chart that you see here, we've largely relied first on the morphology, which is often unreliable, confirming that the cells of interest are indeed of mesothelial lineage, and then employing these molecularly informed immunohistochemical markers, including BAP1 and MTAP, which have been pretty widely validated for this particular differential. And if you see loss of either BAP1 or MTAP, you can usually be pretty confident that you're dealing with mesothelioma and not a reactive process. The challenge here is that you really only get to, and it depends on the study that you look at, but you really only get to somewhere probably between 50 and 60% sensitivity for the diagnosis of a malignant process with these two markers alone. And so we've been kind of hoping that something wonderful would happen with NF2 as a immunohistochemical marker for a while. There have been a number of studies over the years using it, and many of the clones have just been pretty terrible, and it's been very difficult to get reliable results from it. But there's a new antibody that was published within the last 2.5 years, and when we saw that particular paper, we thought we would give it a try for this particular differential diagnosis. So this is just a couple of examples of what NF2 looks like in practice in tissue. This is and the projector's great, which I'm really glad to see. It's much better than what I can see on the screen, but you can get a very nice sense of the crisp membranous expression that you see of NF2 here in this reactive mesothelium example. It's a cytosolic protein that tends to bring together Hippo, mTOR, and RTK pathways and is typically localized to the membrane. In some circumstances, you'll actually see it cytoplasmic, so meningiomas, for example, which often have NF2 in activation. When it's intact or in the meninges themselves, you often see cytoplasmic expression, probably as a function of the very, very kind of tight interdigitating membranes of those particular cells. It just appears cytoplasmic. So here's some examples in mesothelioma. You can see one that's intact, molecularly intact, and protein intact for NF2. There's one in the middle that's an epithelial example that shows loss of NF2, and then a sarcomatoid example on the end that also had absent NF2 by molecular and protein. We'll talk a little bit about the different subsets of meso and the different proportions of tumors that have loss of, say, BAP1, MTAP, and NF2 in a couple of slides. The other thing that's been very interesting about looking at mesotheliomas over the last couple of years in our own genomic databases is that the copy number profiles, I showed you kind of a characteristic one from our patient's epithelioid meso a few slides ago, but the copy number profiles can really be radically variable from one patient to the next. So we see that very kind of quiet diploid genome with a couple of chromosomes lost in some patients. We see other patients who have quite noisy, I wouldn't say noisy, but quite busy copy number profiles with significant aneuploidy. And then we have others that have a very striking kind of LOH pattern or loss of heterozygosity program, which I'll show you was initially described in the same paper from the TCGA that I quickly flashed up before. But they had described this a couple of years ago, and this was a study that was led by Marc Ladanier at MSK. They described this unique subset of mesotheliomas that appear to have a P53 mutation that precedes acquisition or I should say loss of pretty much most of a copy of most of the chromosomes, followed by genome duplication. So you end up with what appears to be outwardly a diploid genome, but it's actually got extensive LOH throughout. So there's a couple of examples of what it would look like before it undergoes whole genome duplication by karyotype in that panel labeled C. And then we can discern that this event has happened by looking at the presence of loss of heterozygosity in the germline polymorphisms of the specimen. And here's just a couple of examples from that TCGA paper. What it looks like at our own on our own panel is something like this. So here's a specimen that when you look at it just kind of briefly in terms of the absolute copy alterations as are shown in the top panel, it looks like most of the chromosomes seem to be kind of near diploid with assorted copy changes up and down. But then if you look at the SNP ratios, instead of our germline SNPs being aligned at the 50% line, which is the green line here in the middle, you can see they're kind of radically splayed upwards and downwards. Again, speaking to the fact that there's this underlying essentially copy-neutral loss of heterozygosity for most of the genome. So the TCGA reported this in about 3% of their cases. We're actually seeing it in close to 14% in ours. And similar to the TCGA, we're seeing this enriched for P53 mutations as well as CDKN2A deletions. So this seems to define kind of a potentially another subtype of mesothelioma. It's certainly not mutually exclusive of the other alterations that we described, but it is a kind of a unique phenotype. Not sure what this means clinically, but it at least prompted us to think about employing P53 as another marker we could use as a diagnostic feature of a subset of mesotheliomas to differentiate them from a reactive process. And we weren't the first group to think of this. The University of British Columbia group, in a paper that for which the first author was Julia Nasso. She's a future thoracic fellow as well. This was published in January of this year. And they essentially showed a pretty good correlation between aberrant P53 staining and the presence of TP53 mutations in mesothelioma. And so we took a similar tack and started looking at our cases for P53. And here's an example of, I don't really know what this is. If this is epithelioid or sarcomatoid or transitional, these are the things nobody can agree on classification for. Suffice it to say, it's a mesothelioma. It has very, very striking P53 overexpression. So this is very much an abnormal pattern of P53. And it also actually had MTAP loss as well as Merlin or NF2 loss. These are a little tricky, right? And actually this case in particular I pulled out because when we first reviewed this specimen, we called the MTAP and the Merlin intact because there's so much obscuring inflammation that it's actually hard to discern that population of tumor cells in the background. When you start to inspect it, you can see the very atypical cells that look clearly to be negative by MTAP. I think NF2 is a little tricky because it's largely a membranous pattern of staining, and so it's kind of like reading a PDL1 stain. What compartment is actually, or what cell type is actually contributing positivity in these cases? So I wouldn't say that Merlin is necessarily for the faint of heart and is not always easy to interpret in all cases, but it certainly is a very useful adjunct, I think, in a subset of our cases. Okay. So when we started to put together all of our data, we looked at about 85-ish mesotheliomas and around 50 reactive mesothelial hyperplasia cases, and looked at the sensitivity of individual markers for the diagnosis of mesothelioma, and then combinations of panels. And I think the take-home point here is if you jump down to the bottom, well, we can point out for us actually BAP1 plus MTAP alone actually gave us a sensitivity of almost 80%. So those two alone are actually pretty robust markers. So if you're content with your BAP1 MTAP practice, if that's what you have at your center, you're not doing too badly. If you did want to add Merlin on to that, you gain another about 11% sensitivity for the diagnosis of meso. And then if you wanted to add on P53, you get up to about 93%. So it's a pretty marginal gain with P53, but you do pick up a handful of cases that you wouldn't have detected otherwise. If you were to do, say, our sequencing strategy alone, without the IHC, you'd have about a 95% success rate in terms of detecting the malignant processes in comparison to the reactive ones. And if you added together the IHC plus the OncoPanel, you get up to about a 99% sensitivity. So we're sort of like, we're really hammering at making sure we're able to get make this diagnosis of malignancy. These are all biopsy specimens. We did not incorporate cytology specimens here. That will be probably an entirely different project. One final, and so what this has, for us at least, led to is this proposal to integrate Merlin staining into a diagnostic algorithm for the atypical mesothelial proliferations. And P53 may be an option, I think, particularly if you strike out with BAP1, MTAP, and Merlin, you might want to bring in P53 as well. Okay, and so kind of getting back to our original case, how much can we rely on these individual markers that we see lost in mesothelioma for discriminating from other malignant processes? So if it's meso versus, say, sarcomatoid carcinoma of the lung, or meso versus breast cancer, which is not a typical scenario that we face, this particular case. But can we use these markers as diagnostic markers? I've always been very reluctant to recommend that strategy because although, yes, you definitely see BAP1, say, much more commonly in meso than you do in non-small cell lung cancers, if that's your differential diagnosis, there's still this small subset, 2-3% of lung cancers that can have BAP1 loss. So in isolation, I think we have to be very careful interpreting BAP1 loss as kind of a clinching feature for mesothelioma. I think similarly for NF2, again, it's going to weigh very heavily in favor of meso, but it's not necessarily going to be necessarily the final word. But kind of combining these things, particularly in the context of a gene panel, may give you greater confidence. And I would just point out in particular that MTAP loss, and I apologize for some of you who maybe don't think about these things. MTAP's right next to CDKN2A on the genome, so we use it as a nice surrogate for CDKN2A loss. This is actually lost in about 50% of pulmonary sarcomatoid carcinoma. So if that's your differential diagnosis, this is a terrible marker to consider in trying to make that distinction. Okay, so let's summarize the first part. I'm hoping that this case shows that molecular profiling can be a helpful diagnostic adjunct. This paired specimen strategy is kind of costly, but certainly a watertight way to confirm relatedness of two tumors and potentially helps to unveil genomic evolution. I would say certainly our thoracic oncologists have been very keen on multiple tumor biopsies over time to really understand evolution of tumors that are undergoing targeted therapy and now immunotherapy. And this is just another example of that. And we're planning to incorporate Merlin IHC into our diagnostic algorithm. We're hoping a couple of other groups will do the same. I've gotten a little bit of pushback on the NF2 or Merlin immunohistochemistry kind of reliability or inter-observer agreement. We'll see. Nobody's done the studies yet. There certainly are cases that will be difficult to interpret and others that I think will be fairly clear. So we just need more practice and publications on the space. And then finally, these quote-unquote meso markers need to be used with caution and differential with other malignant diagnoses. Okay, so let's move on to part 2. And I'm sure many of you will recognize this as the San Francisco-Oakland Bay Bridge in the process of the old one coming down and the new one going up. So maybe another metaphor for our practices. And in particular, I think, thinking about the way we've tried to distinguish between related versus unrelated primary tumors in lung cancer, which is a really huge diagnostic challenge for us in the thoracic pathology space. And sort of the old way to do it was some basic histologic features and some clinical features would enable you to make this distinction. The new way to do this really is increasingly using genomic profiling to figure out if two tumors are related to each other or represent independent primaries. From the standpoint of the clinical relevance, the bottom line is that if you've got a primary lung cancer, your risk of developing another one is much higher than if you don't have a primary lung cancer to begin with. Some of the stats that have been published include the fact that about 15% of patients who have a resected early stage T1A lung cancer will have a second primary lung cancer, typically within 4 to 5 years of that original diagnosis. So that's a pretty substantial percentage of that population. And if you are diagnosed with a second primary lung cancer, not surprisingly, your outcomes are going to be better than if it represents metastasis from the primary site. So it's important for us as pathologists to be able to make this distinction. The other number that you can see up here on the screen is that 15% of patients with at least one screen-detected lung cancer will have multiple primary lung tumors. So these are patients who are undergoing routine low-dose CT screening. These are typically patients who have a certain PACU or smoking history, who are at high risk of developing lung cancer, who will have multiple tumors detected in this process. And so, of course, what we're faced with determining as a pathologist is if they have, say, 2 lesions in a single lobe, does this represent T3 disease, which is typically a trigger for initiating adjuvant chemotherapy, or T4 disease. Similarly, it's going to drive a decision for adjuvant chemo, or M1 disease, in which essentially now you've got a patient who's got metastatic disease in which you're going to essentially palliate them with chemo as well. Or are these all just T1A multicentric tumors, in which case surgery, or say if you're going to do a core biopsy to confirm the cancer, you may want to follow it with radiotherapy ablation. So, sorry for this funny animation, but again, we've been struggling with this challenge of multiple primary lung tumor diagnosis for many decades, and we started out with the Martini-Melamed criteria in the 1970s. And keep in mind, in the 1970s, usually the diagnosis for a lung cancer was either small cell or non-small cell. We didn't get too much more detailed than that. And so it was really kind of advanced to say whether it's squamous or adeno, but those features were essentially all that were used to make the distinction between related or unrelated lung cancers. And then, of course, there was the question of whether there's LVI or what are the clinical features, is there nodal involvement, et cetera. Over the years, those criteria have largely been shown to be obsolete. In the 90s, there were proposals to use comparative genomic hybridization as the strategy for determining whether tumors were related or not based on their chromosomal patterns. At least in our practice, this was not a technology that was necessarily super compatible with the way that we practiced. It was not something we had validated for lung cancers, often needed more tissue than we'd often have available from these types of samples. So it didn't seem like the most practical approach. In the 2000s, we saw a lot of focus on this and much more detailed histologic evaluation to make this distinction in terms of the patterns of, say, adenocarcinoma growth that we're all quite familiar with in the lung cancer space at this point, as well as potentially the use of targeted panel sequencing to identify unique drivers as really more of a relative form of determining tumor relatedness as opposed to more of an absolute way of determining tumor relatedness. There's still kind of a question of what is the gold standard. And we like to think in the molecular space that molecular similarities are the gold standard, but not everybody agrees with that, and we'll see if we can get the whole field to kind of come around. But in any case, this kind of combination of some genomic and some histologic profiling was endorsed by the AJCC in its last edition. But really, since then, we've seen an explosion in the use of larger panel next-gen sequencing, and I think really the sort of definitive study came out of MSK a couple of years ago, where they essentially just took their title from their paper, stating that comprehensive NGS using a multi-hundred hybrid capture gene panel can unambiguously distinguish between separate primary lung cancers versus intrapulmonary metastases. We've very much subscribed to this strategy as well. The challenge, of course, is that many institutions just simply don't have access to this type of testing. And so much of the literature that you see in this space is focused on like 50 gene amplicon sequencing type of panels, and they usually just are not as informative as this type of larger, more comprehensive testing is. So, if you have access to really any molecular testing in your laboratory, one question is when do you actually need to request it? I think in general, if the pathologist is super confident that two tumors are related or unrelated, the data, at least from the MSK group, would suggest you can probably trust them. If the pathologist can't tell, then that's the time to definitely pursue molecular profiling. I would say our clinicians don't necessarily share that view. They sort of like to do molecular profiling no matter what we think, which might be fair. And I'll show you why that might be fair in a couple of minutes, but hopefully we'll get to a point where some of this molecular information can kind of inform our own interpretation of the morphologic features and help us do a better job of making the distinction based on histology alone. A lot of this data has been focused on the adenocarcinoma space, which is fair because at this point in the history of lung cancer, adenocarcinomas are much more common than squamous cell cancers, but the squamous cancers are kind of like now the orphan disease of our thoracic oncologists. Like there's nothing to treat these patients with in terms of targeted therapy. It's like immunotherapy or bust in these scenarios. And they've largely been kind of neglected from the standpoint of what you do with patients who actually have multifocal disease. So we decided to focus on this particular problem in our own cohorts. And we went back and looked at everybody at the Brigham who'd had a resection for a lung squamous cell carcinoma over the last 6 years or so. And we actually found that only about 4% of them actually had multiple lung squamous cell carcinomas. Many patients will have a lung squamous cancer and an adenocarcinoma. As we discussed, those are usually pretty easy to distinguish from one another, but fewer patients actually have 2 squamous cancers, but they're a population that needs a little bit of attention. So we focused on them. And so for those of you in the audience who are inclined to play guessing games based on morphologic features, I'll show you a couple of images and ask you to decide whether you think these 2 tumors are the same or are different processes. One of them is in the left upper lobe. It's a 2 centimeter mass. And then there's another one that showed up in the right upper lobe about 15 months later. It's smaller, it's 0.9 centimeter mass. And so nobody has to shout out if they don't want to, but it could be there's a little bit of additional maybe palisading on this one, but they're both super inflamed. Cells are about the same size, about the same coloration, et cetera. I don't know. Here's another example. In this case, there's a right lower lobe squamous cell carcinoma that was 3.5 centimeters. And then 3 years later, there's another mass that shows up in the left side. This one's 3.2 centimeters. Same or different? Okay, we'll get back to that. So we took these patients who had paired squamous cell cancers. We sequenced both of their tumors on our 447 gene panel. And then we compared the diagnostic call, which was typically either it was made overtly in the chart, as in somebody said, this is a second squamous cell cancer, we favor it to be a new primary, we're going to stage it as such, or they'll say explicitly, this looks like the last one, we favor metastatic disease, we're going to call it a T4 or M1 or whatever. Or alternatively, the pathologist just created 2 separate T stages for it, and we inferred that it is taken to be morphologically or taken to be unrelated tumors. So of the 17 total patients, we had 34 tumors, 17 total patient pairs. You can see that if the pathologist called the tumors morphologically unrelated, over here, because you can't see my arrow here, that we're pretty good. So 6 out of the 7 times we called it morphologically unrelated, we were right by molecular criteria. If we didn't know, morphologically uncertain, there was only 1 case, so obviously we needed help with that. And in that particular case, molecular said that they were unrelated. And then in the cases that we said were morphologically related, we had 9 of those. 2/3 of the time we were wrong. So that's kind of scary because these are patients where we're actually upstaging them, right? We're saying this patient has metastatic disease and we're wrong, and they are potentially getting overtreated. They're getting chemotherapy they didn't actually need. So this argues that we obviously need to do a better job as pathologists of choosing the features to make this distinction, or else relying on a tool that can do it for us. So going back to these cases that I showed you, same or different process for this one. You can see that they actually had 2 distinct p53 mutations. p53 is a truncal alteration in these squamous cell carcinomas. It certainly would argue that these are independent clonal processes, so different tumors. This particular individual, with the 3-year lag between the 2 tumors, contralaterally evolving, we actually called these same molecularly. You can see they have a shared KDR and p53 mutation, and then it looks like they've got some genomic evolution with the acquisition of a PI3 kinase mutation in one and a second p53 mutation in the other. We think these are actually clonally related, which is a little bit scary given how morphologically distinct they are and the fact that there's a pretty significant lag time between the development of these 2 tumors. So thinking a little bit more about the genomics of squamous cell cancers, we've overall sequenced just over 500 of these at the Dana-Farber so far. And in our data set, and this is consistent with what you'll see in, say, the TCGA, the most commonly mutated gene is p53. It's probably mutated even higher than 85%. It's just a function of whether you're finding all of the different potential mechanisms of inactivating it. But this is probably the ballpark. So in terms of looking for a high-yield target, if you just wanted to identify one particular gene that could help you make this distinction, p53 is definitely the one to target. And for our cohorts, 32 of the 34 samples had a p53 mutation detected, but every single patient had at least one. So if you have a wild-type p53 versus a mutated one, that could actually be helpful in making a distinction between different primaries. And there's certainly, as I'm sure everybody here is well aware, there's certainly a very strong precedent for using p53 IHC as a robust surrogate for molecular testing, at least in the GYN. area, and I think increasingly in other tumor types as well. We're using the DO7 antibody on a DACO platform, so we don't have any of the methods that were published here, but all of the methods that they published in this particular paper in an ovarian serous and endometrial cohort back in 2016 showed pretty reasonable accuracy with relation to the presence of an underlying p53 mutation. So then we asked if we could use p53 staining as a surrogate for molecular profiling, and this is kind of the more cost-effective way to go about doing this in this particular differential diagnosis. So what you can see is that we had 5 patients who actually had similar p53 staining patterns. Either they were both overexpressed, both wild type, or both lost. And if the p53 staining is the same, it's frankly not particularly helpful because you can have multiple mechanisms of inactivating p53 that are molecularly unrelated. So this particular pattern is not super helpful. Unfortunately, we had 5 samples where we couldn't actually get a tissue slide to stain, so those had incomplete staining. And then we had 7 patients where the p53 staining was different, and in all of those cases, they were confirmed to be molecularly unrelated. So I think if you decide to do this strategy and you stain your 2 squamous cell cancers and they show you distinct p53 patterns, you can say with relative confidence that these represent unique primaries. Okay, and I'll just show you a quick example, and you can do some guessing on this one as well. This is a patient with a 6.2 centimeter big right lower lobe squamous cancer, had a combination of both basaloid features and some keratinization. That's shown here. You can't see my mouse. And then they simultaneously had a right upper lobe, more keratinizing squame that was resected. This one was, as you can see noted here, was peripherally located, sort of stuck under the pleura with associated LVI. So for any of you who look at lung cancers routinely, I don't know what you're going to say about it. I would look at this and say, huge lower lobe tumor, small nodule stuck up under the pleura in the upper lobe. It looks a little different, but that's the frozen section, so I'm sorry I couldn't get the permanence for this particular one. We called it a MET from the lower lobe to the upper lobe, staged it as T4N0, but did advise molecular correlation. You could argue that it doesn't really matter because they already had T3 disease here based on this large size, and they're going to get adjuvant therapy, but we do like to be right when we stage our patients, so molecular might be helpful. Rather than doing molecular, we could look at the p53 expression, and indeed, this is the lower lobe mass. You can see it's got an overexpression pattern of p53, and the right upper lobe mass actually has p53 loss. So despite the sort of clinical suspicion and pathologic suspicion for METs, we were wrong. These were independent primaries. So to summarize this part, this multiple primary lung tumor problem has been a headache for us for decades. I think we're starting to make some progress on doing this, but we still face the issues of kind of cost and timeliness of making this diagnosis, where I think IHC can come in handy, particularly in the squamous cell carcinoma context. Adenocarcinomas have a much lower frequency of p53 mutation, so it's not quite, I think, as high yield of an exercise. We're talking more like 40% typically, as opposed to close to 90%. Hotspot panels, I think particularly in the context of squamous cancers, are really not going to be very useful because it's unusual that a hotspot panel is going to give you particularly comprehensive p53 coverage, but potentially p53 profiling alone can be really helpful, and IHC is a nice surrogate. Okay, so just practically speaking, at our own institution, you need to profile both tumors to make this determination, which, as I alluded to, can become kind of a cost challenge. We ask the clinicians to very clearly document in the record why they need both tumors profiled and the importance relative to stage determination. We actually don't know if we get paid to do this or not, so still waiting for the data to come back on enough of these samples to understand if we're just sort of eating this as a hospital or if payers are amenable to this process. We're fortunate that we also have an ability to consent patients to research testing. So we do have scenarios where maybe we'll test one as a kind of a clinical sample and one as a consented research sample, or potentially we have both samples tested as research. This often takes 6 weeks, so if you really need to make a quick clinical decision, probably not a great strategy. Okay, and then just finally, I'll just say there's a lot of areas where we're interested in kind of leveraging these sort of quick and dirty biomarkers or utilizing molecular to kind of inform a more efficient diagnostic strategy and surge path. One of those is using p53-IHC to distinguish reactive and neoplastic squamous proliferations in the lung. We have a poster at USCAP this past year led by Nico Wyvekens, who's one of our second-year residents, where we're using molecular profiling to confirm metastatic pancreatic cancer to the lung, and then using that information to really highlight the morphologic features that can allow you to make the distinction between that process versus primary mucinous lung adenocarcinomas. Historically, this has always been a very difficult challenge for us in SurgePath. And then finally, utilizing things like mutational signature calling by NGS to help with, say, like metastatic cutaneous squamous cell carcinomas to the lung versus primary lung squamous cancers. And this has been a huge tool, I think, has been a tool that's allowed us to understand that this actually happens at a greater frequency than we've recognized in the past. And so with that, I just wanted to thank David Chapel, who is one of our GYN fellows, actually with an interest in mesothelioma. We worked with a lot on the mesothelioma markers. He's now on faculty at University of Michigan. He's featured in CAP today, a couple of weeks ago, as one of the hospitalists at University of Michigan. Marie-Pierre Montminy, who's our current thoracic fellow, who's been doing a lot of the work on the squamous cell cohort, and then finally Nico Wyvekens. And this is, for those of you who are familiar with Cambridge, a beautiful artistic rendering of Riverbend Park in Cambridge, Massachusetts, close to where I live. So happy to take any questions in the last 2 minutes before we lose the room.
Can you talk a bit about recurrences under therapy of lung cancer, but the tendency to change in molecular profile?
Yeah, sure. So, we sort of, I think, we've recognized there's these sort of subclasses of changes that we see in the recurrence context, particularly following targeted therapies, where we're seeing one subset of tumors where we're seeing kind of these on target or on pathway resistance mechanisms evolving. Other tumors where we're seeing kind of off pathway resistance mechanisms, and then things that are undergoing like total kind of transcriptional evolution where we end up getting some kind of morphologic shift. So I think in the first class of on target or on pathway alterations, EGFRs are great. It's kind of the poster child, right? So you develop in the first gen EGFR TKI setting, you develop T790M mutations, for instance, that interfere with the efficacy of the targeted therapy. Now that we've moved into sort of next gen, very potent targeted therapies, it's very much less common that we see these on target alterations in EGFR, much more common that we're seeing off pathway. It's like we're really pushing the biology because these therapies are so potent against shutting down the EGFR pathway that it's like the tumor gives up on EGFR and it decides to co-opt a totally different pathway. So we're now seeing ALK rearrangements in the context of a concomitant EGFR mutation that are the kind of the new driver. And we've had a handful of patients like this who have another clear-cut oncogenic fusion, and the patients actually are responding to a combination both of an EGFR inhibitor as well as inhibitor of that particular oncogenic fusion. And then that third class is that kind of morphologic transformation, which I think is really fascinating, and for those of us in SurgePath, so important to keep in mind. In the EGFR setting, we're finding that when you kind of get the shift from a adenocarcinoma to another morphology, it's often small cell. It's often not, sometimes it's like totally clear-cut small cell. It just looks like a textbook small cell, but often it's this weird, it's sort of like it's a carcinoid, or it's a large cell neuroendocrine, or there's a little bit of adenocarcinoma kind of gland stuff left. So it sort of occupies this intermediate space. And I think as pathologists, it's important for us to recognize that it's not necessarily your textbook small cell, but you have to be able to raise to the clinician the possibility that you may not be finding a C797S mutation in EGFR or an ALK rearrangement as a bypass mechanism, but instead you've shifted this sort of transcriptional state of this tumor, and you're going to have to think about a different line of therapy. Colin.
Great talk. I really enjoyed both the cases. My question is about germline testing. So it was relevant, at least in my mind, to two of the examples you gave. So in the case of your rare 3% mesotheliomas that have P53, did you look at germline for any of those? And then second question, you showed having a lock on two tumors being related based on a single P53 being shared. But I wondered, since there was a second P53 in one, is it possible that was a leak from many patients and the lock was germline?
Yeah, so great questions. As you may know, we're not offering routine germline testing as part of our kind of clinical testing at the moment. We have some research germline available. Within the next, we're hoping 9 months, we'll be rolling out paired tumor normal, and we'll be able to answer your questions with much greater certainty. I would say, the patient with the combined both KDR and P53 mutations in both tumors definitely crossed our minds as well. She does have a significant smoking history, and my recollection is that the VAFs that we saw in those alterations fit with our estimated tumor content. Is that for sure, right? Is that enough to say with certainty that those are not germline? Not necessarily. I do think she was also 70 something. So from the clinical standpoint, it's sort of clinically, she didn't really fit with a Li Fran Mani type of picture. But I think obviously these are important questions that we can answer only when we get the right technology.
Yeah, it sounds unlikely. Although the reason I think about it is we've recently looked at Li Fran Mani and prostate cancer, and we're just really shocked by how many people had full penetrance germline P53 and we're under 70.
And we're showing up
their first presentation was prostate cancer. So
yeah, the more we look, the more interesting these syndromes become in terms of the breadth of the phenotypes, right? I think you've shown that probably a couple of times.
Yeah, it was a great talk.
Thanks so much for your questions.
Can I ask one question about the cytology? Yeah, very nice talk. Yeah, we also have a pleural effusion cytology specimen. So we found background loss in meso marker positivity cells. So how do you your institution, cytology, how do you finalize that kind of report?
I think we have very recently come around to calling that. I think it depends on the pathologist. I think we've come around to calling that mesothelioma, but it may not necessarily be at the top line. It may be atypical mesothelial proliferation. See, note, this is mesothelioma, that kind of thing. But it took a little while to get there, and it has to be a pretty clear, unequivocal absence of the markers in the atypical population in the cytology specimen to do that. I have a little bit of reservations around cytology just because we know we have these cases where the fixation is maybe not quite what we need, or there's for some reason antigenicity is diminished. So you have to be absolutely certain that you've got an intact positive control. But it took us a while. Honestly, I think we've had, we probably went for 6 months to a year where there still was a very strong reluctance to call meso when you really just had the cytospecimen and you had, say, BAP1 loss. It could be mesothelioma in situ, right? So you could call it atypical mesoproliferation. Here is the differential diagnosis. But, if somebody's got a chest wall implants and things, then that's not the, that's not the.
Recently we had a case actually,
yeah.
Cytological suspicious. Actually, finally the patient actually went to your hospital. So they get the consultation actually, but I don't know about the final conclusion.
Yeah.
Then in your talk, you mentioned about the MTAP. It's loss expression in the bone marrow sarcoma carcinoma, 50%, right?
Yeah.
Is it due to gene deletion or is another pathway?
I think it's a combination of mutations and deletion. Meso is pretty unique in that when you see loss of CDKN2A and MTAP, it's pretty much always a deletion event. With things like sarcomatoid carcinomas, it's a little bit more of a heterogeneous, I think, mechanism of an activation of CDKN2A. So, NGS is probably going to be is probably going to define what the mechanism is. For the MTAP loss, it's, I should say, MTAP loss. So CDKN2A is going to be inactivated by a variety of mechanisms. MTAP, when we see it lost, it's pretty much always because there's a deletion. It may not always take out all of MTAP. This is one thing we found from our particular cohort is that the correlation between gene deletion and the IHC loss is not perfect. And if you just look at say the kind of clinically reported out MTAP status from say the OncoPanel reports, it will often say it's intact, but the IHC is lost. But then when you go back and look at it, you look at the sort of the copy number profile manually, you see there's a CDKN2A deletion, and then there's like one exon of MTAP that's part of that deletion fragment that's taken out the gene, which wasn't necessarily discerned when you just kind of do your kind of global overview of the chromosome. So that sort of the alteration that impacts MTAP can often be relatively subtle.